marketing specialist, and today I will be the technical host of this webinar. And before we start, few words about technical moments. During the presentation, so your microphones will be turned off. If you have any question, please write it to the chat. The chat bottom is located below the screen. After our speakers will finish their presentations, we will start answering questions from the chat and also turn the microphones on so you can ask our speakers by voice. And please don't hesitate to ask us in chat or by voice because it will be very useful for us. And also before we start, I just want to remind you that next week on Tuesday, we will have a PSG webinar, methodological and technical aspects of PSG testing on neuron spectrum 65. Don't miss our webinar next week, and the link will be the same. So let's go back to our today webinar. It is EMG and EP hands-on expert techniques. And our speakers today will be Mikhail Babayev, Neurosoft EMG Product Manager, and Evgeny Gulayev, Neurosoft Medical Consultant. So let's start. And Mikhail, please start your presentation.
Thank you, Anastasia. Good day, ladies and gentlemen. Now we begin our third series of EMG and EP webinars. And today our theme will be EMG and EP hands-on expert techniques. My name is Michael Babayev. I am EMG, EP and ERG Neurosoft company product manager. Let's get started. What is now going to be? At first, a bit of theory, when I'll tell you about expert techniques and how it works inside the human body. And then will be more practice when our doctor, Evgeny Gulayev, will show you some expert techniques on the real patient. What are EMG and EP? There are techniques that help us to record and analyze electrical signals from our neuromuscular system, including spinal cord and brain. Now a bit reminder, a bit of anatomy. Here you can see a slice of a spinal cord, and here it is an upper limb of the human body. When I would like to move a limb, electrical signal from the brain goes down to the spinal cord and then through the peripheral motor nerve to the muscle, activate a muscle, the muscle can be contracted. On the other way, if you affect a sensory receptors in skin, this one, they produce electrical signal that goes up to the spinal cord, then up to the brain, and in the brain we can recognize it as sensation. Here it is a muscle and its slice. On the slice of the muscle we can see a lot of muscle fibers. Usually one muscle has up to a few thousand muscle fibers. Here it is the slice of a spinal cord. We can see motor neuron here. One of its axons go through the full length of the nerve to the muscle. It splits into the branches, and this branch with the terminals connects to the muscle fibers. Motor neuron, its axon, and few muscle fibers that are connected to this axon represents motor unit. Motor unit works on the principle all or nothing. And here, between terminal of the nerve and muscle fiber, there is a very small but very strange and very complex part of our neuromuscular system. It is synapse. Here it is. In this picture, you can see nerve motor fibers and muscle fibers. Here it is muscle fibers that will be contracted when muscle contracts. And between the terminal of the nerve fiber and between muscle fiber, we have such a system as synapse. It is a very strange system because it works not on electrical but on base of chemical reaction. Here from the brain, from the motor neuron comes electrical signal. Also, electrical signal will spread. Electrical signal spread through the muscle fiber. But here it is chemical reaction. There are a lot of small bubbles inside the terminal of the nerve. They has a name synaptic vesicles. This bubble contains neurotransmitter fluid. Normally, each terminal has a few thousand such small bubbles. And when electrical signal comes from the brain, these synaptic vesicles go to this synaptic cleft and eject their fluid here. And so the signal can be transferred to the muscle fiber, and muscle fiber can start its contraction. I think this very strange and chemical system is a mistake of the nature. Because in the nature, in some other animals, we can see electrical synapses. That is much more simple. But here in the human body, we have only chemical and very complex. And if it is very complex, sometimes we can get some problems with this synapse. Sometimes this transmission, neuromuscular transmission or neuromuscular junction can be very poor, not reliable. And but if you have EMG machine, it is very easy to examine this system. It's possible to do it, for example, with decrement test. As you remember, during our second webinar, our doctor have shown you this decrement test. Only small reminder. You know that if you apply electrical stimulus here on the motor nerve, the excitation will go to the muscle. Muscle will be activated and contracted because of this stimulus. And we can apply this stimulus few times with some rate, with some frequency, and get a few responses, as you can see in this picture. First response has a very high amplitude, it's good one. Second is lower, third is lower, and so on, lower and lower. Why are they lower? Because of problem in synapse. Because the neuromuscular junction has low reliability. Maybe not enough synaptic vesicles or some other problems. But sometimes, if you made a decrement test and don't understand, do we have decrement or do we not have decrement? Or maybe sometimes, if it is not possible to make this test, you can use some other technique with the name jitter or single fiber action potential. You can see it here. Here, two single fiber action potentials. Here it is single muscle fibers, and here it is their action potentials. Action potential of one muscle fiber and action potential of the other muscle fiber. How we can record this signal? We put small needle into the muscle near the two neighbor muscle fibers from the same motor unit. And we ask a patient to make small muscle contraction. Our brain sends activating signals. This motor unit will be activated with some rate, and we can record some signals, action potentials. Usually, this delay between two action potentials of the muscle fibers should be constant if you have a good synapse transmission. But if you have some poor neuromuscular junction, some problems with it, you can see some jitter, because the interval between these two action potentials will be sometimes shorter, sometimes longer, and we can see such a jitter. It tells us that we have some problems with the synapse. Reflex arc. Reflex arc, it is very interesting system inside the human body. Let's also small reminder. If we make some stimulus, apply some stimulus to the receptor receptors in the skin, sensory receptors in the skin. They produce electrical signal that goes through the sensory nerve to the spinal cord and then go up to the brain. And in the brain, we can recognize it. On the other way, if you would like to move a limb, our brain sends a signal through the spinal cord here to the motor neuron, then through the motor nerve fiber to the muscle. Muscle will be activated and contracted. But you can see here very strange additional neuron. It is interneuron. As you can see, it connects sensory fibers with the motor fibers and create reflex arc, special loop. How it works? If, for example, you put your finger into the flame, it will be very strange effect, very strange impact, and very big signal will appear here on the sensory receptors. This big signal will go to the spinal cord, go up to the brain, but if it has very high amplitude, it will excite this interneuron. It will be excited, and it in its turn will excite motor neuron, and signal will go to the muscle. Muscle will be contracted, and we withdraw the hand from the flame. It is important to tell you that this system works without our brain. If, for example, this interneuron will be absent here in the spinal cord, how it will work? We put finger in the flame. It produces very high signal. This signal will go to the brain, spinal cord, then up to the brain. In the brain, we will recognize that it is very painful, and brain will send a signal to the muscle through the spinal cord, through this motor nerve. Muscle will be contracted, and we will withdraw the hand from the flame. But it will take too long time. I'm sure in this, it will be situation -1 finger. It will be too late. So this reflex arc will save our health, and sometimes it saves our life because it is very fast, very quick. In the human body, we have a lot of different reflex arcs with 2 neurons, 3 neurons, many neurons. And if you have EMG machine, it's possible to examine such reflexes. Maybe you know H reflex, blink reflex, R3 reflex, and some others. Also, we have such a technique as T reflex that can be done with special tendon hammer, with electronic tendon hammer that is connected to the computer or to the EMG machine, and that is synchronized with an amplifier. When we made a stroke on the tendon, it's synchronized with an amplifier at 0 time, and with small delay, we can get a motor response. Now, a lot about tunnels. Here it is carpal tunnel. You can see in this picture our palm and a slice of a carpal tunnel here. What we can see inside this slice? A lot of part here took carpal bones, because here we have a joint, so they are very big in size. And also we can see here a lot of tendons. Why they are present here? You know, we can move fingers. We can move our fingers, but where are the muscles? Muscles from the fingers are in the forearm. They are far from the fingers, because in the palm there is not enough a place to put muscles here. So fingers are here and muscles are here, far from it. So we have a lot of tendons here. It is ropes that pull our bones, and so we can move fingers. And we have a lot of fingers, and each finger can make a lot of different movements. So there are a lot of tendons here. And you can see a median nerve. Median nerve. Really, there is not enough place for median nerve here. not enough place. And sometimes because of inflammations, because of trauma and so on, median nerve can be compressed. It can be compressed, and its possibilities for electrical signal conduction will be decreased maybe dramatically, and it start to suffer. And for example, we can see some area of numbness or some other diseases. But if you have EMG machine, which is very easy to examine this tunnel and understand what will be exactly point of the struggle. It is possible to do with such technique as sensory engine. Here you can see we can place recorded electrodes on the finger, on the nerve terminals, and we can apply a few stimulus, put electrical stimulator here and make few stimulations with only small steps. We only shift electrical stimulator by 1 centimeter. So we can record a lot of waves and understand what is the exactly problem point. Here you can see 6 traces. With first third of them, we can see that the latency of the wave did not change, did not have a big change. But with other 3 responses, we can see that latency changed much more bigger. It is very clear from this graph. First 3 traces and other 3 traces. So it is clear for us that the problem is between third and fourth traces. Very easy. Motor unit number estimation, MUNI techniques. Previously, I've told you that each our muscle have up to few hundred motor units. Why it is necessary for us to understand, to estimate the real number of motor units? Let me explain you. Here in the picture, we can see it is schematic picture. We can see 2 motor neurons that are located in our spinal cord and their axons that goes through the full length of the nerve to the muscles. And here it is muscle fibers. First motor neuron is connected to 3 muscle fibers and second to 2 muscle fibers. It's only schematic. Sometimes we can see a situation when an axon of motor neuron can be damaged. Or for example, motor neuron can be regenerated, can be dry. And in this situation, muscle fibers become denervated. They are not innervated anymore from the axon. They become single, they become alone. And in this situation, if they become alone, they start to send some signal, SOS signal, save our soul signal. It is fibrillations. They become to start fibrillations, and the nearest axon receives these save signals and start to grow a new terminal in this direction of this signal. And this new terminal go to this muscle fiber and create a new synapse. So these muscle fibers will be innervated. This system has a name, terminal sprouting of motor axons. As you can see in the last picture, all muscle fibers are innervated. And if, for example, we would like to record CMAP wave, compound muscle action potential response, or M wave from the muscle, when you stimulate it, we can get a normal response with a big amplitude, normal duration. But sometimes in some diseases, for example, maybe you know ALS, amyotrophic lateral sclerosis, we can get problems with many motor neurons in the spinal cord. A lot of motor neurons can die can degenerate. But if we record motor response, CMAP, we will get normal amplitude. But in this situation, it is very necessary to understand how many motor neurons are dying, so how many motor units can decreased, and how many motor neurons are alive. And if you have EMG machine, it's possible to do with such a motor unit number estimation techniques. In our system, we have 4 different techniques. One of them here, you can see it is Munix. It will be shown you today. And the last technique I would like to tell you about is somatosensory evoked potentials. On the second webinar, I've told you, maybe you remember, that with the evoked potentials, it's possible to examine a full sensory pathway from the fingers up to the brain. For example, if we stimulate a finger, near nerve terminals, sensory receptors in the skin will produce a signal, electrical signal that will go through the sensory nerve to the spinal cord, then up to the brain. And if we put electrodes on the head, we can record this signal. But the problem is that the amplitude of this signal is very, very low. And it is not possible to see it on the background of EEG activity. But if we make a lot of stimulations, apply a lot of stimuli, and record a lot of traces synchronized with this stimuli, and average these traces, EEG activity will be removed because it is chaotic. And our response will be very clear visible, as you can see in this picture. Okay, that's all I would like to tell you. And now our Dr. Evgeny Gulaev will show you these expert techniques or some other expert techniques on the real patient. Thank you, and please, Evgeny.
Good afternoon, dear colleagues. Today we will discuss and try to illustrate practical parts of different EMG and evoked potential methods. First of all, we will start with somatosensory evoked potentials because to save some partly time, we applied electrodes, but I will show how to do it. For somatosensory evoked potentials, it's registration by electrical activity from different levels, from cortical level, spinal level, and plexus level. We will register three-channel of evoked potentials. For that, we will use our 3-channel EMG machine light box. We will register answers from these through lines from electrical stimulation. We will register somatosensory evoked potentials with median nerve stimulation. So for registration, we usually need to use cup electrodes because we need a very good impedance, very low impedance. So we need to very carefully prepare skin. So we should use alcohol and also some abrasive paste before set electrodes. And after that, we add cap electrodes with adhesive paste. After that, we set electrodes. So this time we register somatosensory evoked potentials from median nerve. So we set contralateral primary sensory cortex, S5, S6 spinal level, and both of these channels registrate to reference FZ electrode, and also we registrate peripheral nerve, which we registrate ipsilateral air point to contralateral air point. So also we need ground electrode. Usually it must be set between stimulation and registration channels. For example, on arm and stimulation. Stimulation we need use averaging about from 100 to 500 stimuli. So we need constant stimulation. It's better to use adhesive electrodes than classical bar electrodes. So we prepared all methods. Now we can open them in program. So we can use open it. It's already open, but we choose short latency. Sorry, demonstration. Yes. In our program, we can choose in menu toolbar, main toolbar, short latency evoked potentials. We started in that. So we can see parameters of simulation, maximum averaging. For example, we can stimulate up to 1,000 or sometimes more. It's amount of the stimulation connect with the level of the noise. So we will check how it will be. We start stimulation with low intensity. Usually we need to stimulate about 2-3 times higher than sensory threshold. So, and we stimulate usually at the level of little twitch of the thumb for median nerve. So we gradually increase the stimulation. But first of all, we again must check impedance. So it's quite good impedance for cortical and spinal level, and some bigger for air points. But answer, it's good for this answer. So we can a little bit light some better, but in general it's okay for us for peripheral level. So we start monitoring. You can see 3 channels of registration, and now we can start gradually increase stimulation. So at first we can start with single stimulation to look increase up to little twitch of the thumb. Now I can see it. It's about this level. So and now we can start the repetitive stimulation for. So we started. Usually it's better to use classical tool. As I said, it's a connection with different level of noise, and the measure of answers. We can use from 200, 500 to 1,000 electrodes. Now already in online we can start peaks on all 3 channels. So it's a peripheral answer. It has the least latency. It's spinal level and cortical level. Now really it's not bad. We can stop that registration for this clinical for this demonstration. So really we can mark them. We know it's N. So for peripheral level we use N9 peak. For subcortical level it will be N13, and for cortical N20 or N18. So we can start them, set them. and then 20. So automatically the program calculate all parameters. Now we can see the normal, and we can a little bit move them. So for all types of evoked potentials, we need to reproducibility. So it's better to repeat our stimulation. We will do it. And we can use smart sensor evoked potentials for control integrity, for estimate dynamic of the process, and also we use it at unconscious states and to check integrity or domination of different spinal or mostly central nervous system, sometimes peripheral nervous system too. So you can see a good reproducibility of the answers on all three levels. So for demonstration, it's sufficient. Okay, we can superimpose them. You can see very good. So I think we can finish that with some sensor evoked potentials. So that's the first part of our investigation. Now we will go to several methods with stimulation myography. We will put away electrodes. So next we will show inching methods. So it will be sensory and partly motor inching. Inching study is investigate short distances of the peripheral nerve to localize more accurate points of different problems, mostly with different local neuropathy, for example, in carpal or cubital tunnels syndromes. So first of all, we will start with sensory inching method. For this, we will use ring electrodes. We should prepare skin with alcohol, swab up a little skin, because we set active electrode more proximal and as usual, and active more distally as for any sensory nerve study. So we will straight by default all sensory neuroconduction study set in second channels in this machine. So we will stimulate with bar electrode. We can leave at the same place our ground electrode. So now, usually inching methods developed after the normal sensory conduction velocities. So methods is connected with gradual change position of the stimulation electrode from different from both waves, proximally and distally from the wrist. Sees for the carpal tunnel for the median nerve sensory instinct. So we start stimulation most distal. Usually it's about half of the palm. We start stimulation. We need to get a good answer. It's a little bit water the stimulation electrode.
Evgeny, screen demonstration is not activated.
Oh, I'm sorry. So you can see I gradually increased intensity. Now it was about, we have a very good curved line, so we can start stimulation. We have a good high amplitude peak, so we can increase the latency or intensity of stimulation some more. It's already with artifact. It's okay. We also can add some gauze between fingers. It sometimes decrease the stimulation artifacts. Yes, it's some better. So we it's okay. Good answer. The first point. Now we change position from 1 centimeter. Sometimes we can use 2 centimeter distance. Some doctors prefer. We increase it. So at each level, really the depth of the nerve is different. So we need to change intensity. It's okay. In ancient methods, we usually use peak latency because it's more accurate. Next point. Increase latency. It's okay. Next point. It's 40 microvolts. It's okay. Next point. Here already we can decrease the intensity because nerve is closer to the surface. Yes. Next point. Yes, we can choose it with right as initial trace. Okay, next. We can see good answer, but the beginning of the marker is not right, but we use latency. So in the last, for example, okay. So we can change position of markers, but now really we measure latency peak latency, so it's okay. We see that it's gradually increasing of the latency without big jumps.
Evgeny, please see on the 6th trace there is no response. Please mark it. On 6th trace.
Yes, sorry. we can set electrode with ELT. So really up to 0.4, it's absolutely normal. Usually big, if we have increasing more than 0.4, sometimes even up to 1 millisecond in 1 centimeter distance, it's a problem. So we localize problem. Now it's okay. So it was a sensory imaging. Now we will develop partly motor imaging with. So if we use sensory imaging mostly for carpal tunnel for localized position, motor imaging mostly developed for elbow level, but today we will with ulnar nerve, but we will show it for the medial nerve too, for abductor pollicis brevis. So we will set electrodes for abductor pollicis brevis. So now we set electrodes, ground the same place. So we already have a scale, so we will use almost the same scale for motor imaging. Yes. Now we set demonstration. We choose in our program motor imaging, carpal tunnel, right hand. We use the same type of stimulation, and we can stimulate a middle palmar, for example.
Evgeny, it is second channel. On the device, it's second channel.
Yes, that's right. So we need to. I didn't insert a toe yet, so it's better to check impedance. So sometimes. Now we can a little bit wet electrodes to decrease impedance. Now for motor imaging, it's appropriate. So we again stimulate with different level of stimulation. Supramaximal level, usually we already perform this after conduction velocity. We know the supramaximal level. It's here. Change position. The next point. This place nerve is much deeper. Yes. No, it's very deep. Yes, now it's okay. It was ulnar nerve additional answer. Delete trace. Go further. Further. It's much higher level. Really, we need really it's about 13 millivolts. So initial answers we should repeat for clinical purposes. But now for demonstration, it's the same as the sensory imaging, so we can go further. this part was developed right, so we can see no gradual increasing, and this was the seize of the wrist. So now we go to the next method. So we will use cutaneous silent period. It's methods which is connected with small nerve fibers. So for that we will stimulate distal nerves, peripheral sense with electrical with electrical stimulation of pain sensors now, and registrate activity of the abductor pollices. So we set the same localization, and we will stimulate the second finger with bar electrode. For these methods, we ask patient to tend the muscle. Yes, so you can see here, but we choose demonstration. Yes, yes. So we demonstration. Now we choose cutaneous silent period for medians, right? This technique needs a very high high intensity of the electrical stimulation, so it's quite painful for the patient. So we will ideally we need to increase our stimulation up to 80, 100 milliamps with duration 0.2, 0.5. But now we can get it some less level. You can see monitoring. It's a tension of the muscle. We stimulate it with about, we start with about 40 milliamps. We increase, it's a beginning of that. 1, 2, 3. Yes, you can see already at this stimulation level. 1, 2, 3. Yes, okay. And the last time, usually we need 4, 5 times. 1, 2, 3. Yes, okay. First, we can delete first trace, but this is okay. We can superimpose them, and you can see silent period. It's a classical about 60 silent period in milliseconds. So it changed its duration throughout different neuropathy, for example, carpal tunnel syndrome. Ideally, we should increase some more, but for demonstrations, very clear. Okay, silent. Cutaneous silent period, that's all. Next will be Munich's method. Really, for Munich's method, we use also classical muscle abductor pollicis brevis. We use the same stimulation. So we need different types of tension, as Michael said. So first of all, this methods for this method we need to perform the motor connection study with registration of compound muscle unit potential. So we will start demonstration. Now we go to the Munix. Munix and also SIMAP scan methods to estimate motor unit units. So we choose Munix, abductor pollicis brevis, right? First of all, we need go to motor next study and do it. Wait, I change. Mistook with electrodes. So now for Munix methods, it's very important to get the high level, the highest level of SIMAP, compound muscle potential. So we usually it's better even change several times position of electrodes to find this place. It's not good. So we will use that one. Okay, it's quite high latency. Now we can go again to the Munix test. And we need to ask patients to a different level of tension of the muscle registered. So please, tension, okay. Ideally, we need get up to 20 different tensions levels, but at example 3 and more, we already will see the line. Some more. Some lighter. Increase please latency. So, increase tension, please. Yes. Some more. We can see our line. So we can ask, cooperate with patients to stimulate at different levels. You can summarize. Okay. And we most light tensions we don't use for estimation. Some higher tension, more tension, yes. More tension, yes. And already we can see the curve quite good. So it's a Munix about, there are different data about Munix normal values. So, but it's semi-scientific methods nowadays. So we can go, that's all. We can go up to 20 methods, 20 curves. Now we go into the next methods. It's a map scan. For that, we use again the same position of the stimulation, but we need constantly standard stimulation, so we will use it's better to use other electrodes. Self-adhesive for copper electrodes for stimulation, because we need constant stimulation. And the points of the previously we set with median nerve points of stimulation. So now we can go to our new second, again, median nerve, right? So this method is connected with stimulation. We set it with touch proof, or you can use classical DIN stimulation with other this. Now we will set DIN, change to touch proof. So we through methods we need a lot of compound muscle in potential. So first we set several stimulation for initial estimation of the level. So we can stimulate, find the okay. For example, 5, 10 initial stimulations. On this data, we will then generate stimulations program. And at first, initial. So, yes, okay. You can see here that it's at the curve. We can see its first line. It's a threshold response. We set it as a threshold response, and also we can see that is a supramaximal response. We set it as a maximal response, supramaximal stimulation. So on these two parameters, program can let us to create stimulation protocol. So we can see it will be 500 stimulations between this intensity, between 6 and 19 milliamps, with stimulation frequency 2 Hz. Now, as I said, it's better used to adhesive or copper electrodes for stimulation because it's more stable. And we can start stimulation, repetitive stimulation. You can see it's gradual decreasing of intensity. Up to, it will be up to threshold level. You can see, we will wait 500 times. a little increment of answer, but now it will be decreasing. It's not very comfortable for patient, but not very painful. But compare with Munich methods, we don't need cooperation with patients, so gradually decreasing methods. And normally, it will be a very smooth curve without any big steps. So when patients have a big problem with motor neurons, it will be big gradual jumps in answers. Now you can see it goes very slow decreasing without any problem. Now it will the amplitude of the answer will decrease more fast. Usually it takes about up to 5 minutes. Now we can see this main slope of the decreasing without big intervals. It's absolutely normal. We get a very nice curve. Without any problem. Let's wait, it's soon finished. Already contraction of the muscle much lower. A little longer. And now there are different methods to estimate these steps. Mostly now it's scientific research mostly to estimate, for example, with lateral sclerosis. Very classical S shape of decreasing. And also this we can very smooth position of the SMAP. Compound muscle. So really, we it said too many scales, or too many steps really, and we can remove them. It's not true because but we can change the. So at maximum, I can see this little step, and maybe here we can change position of them, and we can count steps, count process. Now this we can remove. This also remove. No, it's certainly absolutely normal curve. That's all. So we finished with this method. Now we will do T reflex, a standard reflex with a special electrical hammer, stimulation hammer. So we will use biceps reflex, bicipital reflex, and we need to set electrodes at the biceps, the active electrode at the middle of the bicep muscles, and reference at the level biceps with deltoid. We will use this hammer. We insert that in the USB. So now we will show it. We choose the T reflex, biceps, right. Impedance okay for this curve. We need to turn on additional filters for more smooth curve. Okay, and now we will choose stimulation and perform hammering. We need to relax patient some wait a little. Relax. Oh, at last we can see small answer. They're not very high. Yes, okay. It's not count from 100 -7 and further. Yes. Sometimes we can. No. It's not very high, really reflex. Here's where. Okay, our first four, no, not very high, but it's sufficient for us for estimation of them. We, for demonstration purposes, we will estimate the maximal of them. For example, that almost nice answer. It's for we can use it for quantitative analysis of tendon reflexes, for example, for scientific work or something like that. We can use estimate biceps, triceps reflexes, and masseter reflex with this hammer. Now we can go to the needle EMG methods. First of all, so for needle EMG, we will do jitter methods and macro EMG. So we will use at first jitter of. We will use extensor digitorum muscle. We can we insert the connector for needle. Put away some things. So we'll put on gloves. Where are they? Must put on gloves. For jitter, we will use small needle EMG, facial or needles for children. We scrub up the skin. Ask patient to move. Okay, find the muscle. Okay, relax, please, muscle. We can insert the needle. Now we will start in the program. So, single jitter method. So it's extensor digitorum right muscle. Yes, you can see. Yes, we in jitter method we have another filters from classical concentric needle EMG. So we have a little bit another curve. So now we will ask patient to contract. It's sufficient. So now, okay. Now we estimate it has much stronger filters, and we compare several muscle fibers from one motor unit. So we agree this, for example, to gloves. Stop. So we need get up to 20 of them. We compare slope set markers, and on slopes we use automatically registration of jitter. Normally it must be up to 60. So first now we change position of the needle a little, and we'll register. Contract, please. Some more. Change position of the needle. Contract, please. They were unstable. It's a summation of different motor fibers. We need relax, please. Yes, it's not good. Further. And so we need to get up to 20 this manner. 20 pairs. Relax. Sometimes we can find them more quicker. It's ideally we have 50 up to 100 traces of every. So we set we can a little move markers on slope from both parts. It's important to set it rightly. Yes. And press contract. Yes, good. And so we can, it's not ideal, but we can use it. Triggering was with and now we can check it's not good. We need to add, because it's summation of other, it's not a single fibers and single group fibers. Here we need to change position of markers. really also summation. It's not ideal. And yes, it's much. Ideally, it must be between 0.8 and 0.2, and it's summation of different muscle fibers, so we need to exclude it too. Ideally, they must have the same shape and the same very good slope, but they have a very different way. So now we will set insufficient amount of them, but you can see certainly it's a good normal jitter for pairs which we set normally. Also, we can, if it was the same good form, but it's not, we can copy this and measure jitter between this. Also pairs. But now you can see the jitters and this histogram is normal. Abnormal jitter is more than 60 microseconds, and it's sometimes per myasthenia gravis or something like that. It can be more than 100. So something like this. We will not demonstrate today stimulation jitter, but it's developed mostly for facial muscles, for orbicularis, oculi, and frontalis, with needle or adhesive electrode stimulation. And the last, we will use perform macro EMG electrodes. So we will use the same needle. Macro EMG we will registrate with concentric needle. We will use two-channel macro EMG registration. One channel will be concentric needle, as usual, but second channel, in first channel, we will registrate activity between core and cannula of the concentric needle, and second channel we will registrate active electrode cannula of the same concentric needle, and the second will be a surface electrode near this. So we will set, and we need to use connector. And combine so from this DIN electrode we have minus, it's a core of the concentric needle, and it's a cannula. So when cannula will be of the concentric needle will be reference electrode for the first channel and the active electrode for second channel. And reference electrode for will be surface electrode. We apply it on skin. So we use this connector as a bridge. Now we can start in the program. we choose micro EMG, extends indicator on right. So as you see, you can put by default 2 channels. Check impedance. It's a little bit, it's a small core. It has a very small core because it's children electrode, but are they okay? Ask contract, please. So you can see high motor unit potentials and some less macro potentials because they are much closer to muscle fibers. To stimulate. It's a new notebook. So we need to choose not free run and trigger synchronization and device additional steps. Now we can ask patient to contract, set trigger, yes, set. Yes, you can see it's smaller, but it's okay. We change triggering, police control. Change position of the needle. Yes, we can measure it. Some lower. Yes, okay. It's a very nice move. Contract, please. Some lower, stable. Yes. It's more good than previous. Relax. Change position. Contract, please. It's not contract. Oh, it's other muscle. Can try to find contract. Oh, it's a machine. Contract. It's not very high. It's not. Yes, okay. Now some change position of the trigger. Contract. It's not very classical, really. Okay, in the same manner, we get up to 20 electrodes. Now we can see several nice answers, and some of them must be higher, but for example, we need to add up to 20 of them. So not ideal, but we will finish. Our patient is very tight. Thank you. I think we can stop. Thank you for your time. Questions? Maybe we'll go to the questions.
Thank you, Evgeny. Very nice presentation. And very great thanks to our patient, Michael Miloslavsky. I think it was very hard for him to bear so much pain. Thank you, Michael. Let's go to the questions. From Carlos, always is with contraction in fingers, the electrical stimulation is in the wrist. I think it is a question about cutaneous silent period. Yes? Yeah. Because this question was asked during this technique. In this technique, it is necessary to do it with the muscle contraction, because the goal of this technique is to see this some gap during this interference pattern, interference contraction signal, electrical signal from the muscle. And in this situation, we stimulate sensory fibers and record a signal from the muscle.
Yes, really, it's spinal reflex, spinal inhibitory reflex.
Okay, another question from Simon. I hope you are fine. Yes, we are fine here. Thank you. Have you any upgrade handbook including unit, jitter, CSP, T-reflex as so today? And Simon gave us his notebook, but I would like to tell you that this handbook is not the last one. I can share now my screen, and I can show you that our handbook now is not from 2009, but from 2019 year. It is a fresh one. And in this notebook, you can see also needle techniques. For example, needle EMG and jitter. These techniques can be seen from this handbook. But unfortunately, we do not have some other techniques. They are very rare. They for experts techniques. And I hope that our today webinar will help you a lot to understand these techniques. And I hope in a few days, we will put this webinar on the internet and you can download it from YouTube. Another question. Okay. Thanks. As I see, we made a very great job because we have only a few questions.
I have a question. Why, Eugene, why did you ask Michael to count down in T-reflex?
Because he can inhibit by cortically can inhibit all tendon reflexes.
To release reflex, right?
Yes. When we
I can answer. Do you hear me, colleagues?
Yeah.
I was looking at that screen and was controlling the effect which I make there. And that's why maybe I influenced somehow the result. And to avoid this influence, Evgeny switched me off this process.
Yeah, I saw sometimes they ask when they do reflex on the left hand, sometimes they ask to up right hand and do some.
Yes, ask to tangent different other muscles or calculate from 10 minus 7 and go different methods, but we need to change tension of the patient from the tendons.
Yeah, we have question from Vishal Saini. Can you please provide this handbook? So this handbook is a part of device manuals. So it goes with the device. Each time when you get the device, you get the link to download the manuals. And this book is one of the manuals which you can download. But you can write to your accountant in the commercial department of Neurosoft, or you can write to me, and we will provide you the link to download this handbook. It's a really handy thing. Michael, yes, maybe you would open some pages of it just to introduce what is this, because I'm sure it is not familiar. Most of people, not everybody are familiar with it.
Okay, I can show you some pages.
Maybe you start with the title.
The title. EMG studies using Neurosoft digital EMG and EP systems by Sergey Nikolaev, our consultant, very famous in Russia. Maybe one of the famous EMG specialists in Russia.
Not only.
Yes, not only, but in other foreign countries. Here it is from the very beginning. What to do, how to start the program, how to create exam, what buttons it is necessary to press, and so on. You can see how to input patient data. You can see how to start examination, how to place electrodes, and with all possible points. Here, how to measure impedance, how to place electrical stimulator with all possible information, with all possible tooltips, and so on. And how to do examination with the keyboard, with the dedication keyboard, and what you will get on the screen, how to analyze, how to use another stimulation points, and so on. It is very useful book for EMG specialists, especially for the beginners.
All right, thank you.
Okay, thank you, Michael. Thank you, Evgeny. Thank you, Nikolai. I just want to remind our participants that now you can turn on your microphone and ask our speakers by voice. So you can do it right now.
Yes, please don't hesitate to ask us any questions. And our expert doctor, please. We made a really great presentation because no many questions.
All right.
Thank you, and please, Anastasia.
Yes, thank you. I just want to remind you that next Tuesday we will have PSG webinar, methodological and technical aspects of PSG testing with Neuron Spectrum 65. So join us next Tuesday by this link, and don't miss our webinar. Thank you so much for joining us today, and thanks to our speakers.
Thank you very much for your attention.